This is my second patient assessment for adult gynecological acute care nurse practitioner. This is the acute care class. I have Mr. PK, a 27-year-old male who came to us with complaint of seizure activity from an outside facility. He quit drinking about 3 to 4 days prior to arriving at the outside facility, and he had 3 to 4 seizures there, so they sent him to us for higher level care since we can do continuous EEG. So when he got to us, we hooked him up to an EEG. We also got the history of he was drinking 2 to 3 beers a day, but his girlfriend stated that he was actually drinking a liter of vodka a day, and that he's been doing that for the last 4 to 5 years now. He quit drinking about 3 to 4 days prior to the seizure activity. They did end up giving him several doses of Ativan at the outside facility. He ended up getting 12 milligrams total before he got to us. We have a past medical history of anxiety, which he was diagnosed in 2016. We also have a past surgical history of none. His social history, he drinks about 1 liter of vodka a day. He denies illegal drug use, but does endorse smoking just socially with his friends every once in a while, maybe 2 or 3 cigarettes. He is the only child. His mother is alive and has a history of hypertension. His father is alive and has no known medical history. His maternal grandmother is deceased, but did have a history of cancer. And his maternal grandfather is deceased also. He died of a heart attack. His paternal grandmother is alive and has hypertension, and his paternal grandfather is alive and has stroke history. On review of system, he denies any headache or hitting his head at any time. He denies any pain, masses or growths, denies any tinnitus or nasal drainage. He denies any shortness of breath, cough, wheezing. Cardiovascular, he denies any chest pain, lower extremity edema, denies any orthopenia. GI, he denies any abdominal pain, any difficulty swallowing, nausea, vomiting, or diarrhea. He denies any color change to his urine, any urgency or hesitancy while urinating. He denies any bruising to his flank, feverish chills, or any recent weight loss. He denies any numbness or tingling to his extremities, weakness or dizziness. He does endorse anatomic aphasia, and he denies a headache. They did state at the outside facility that he was hallucinating, but by the time he got to us, he was denying any hallucinations. He denies any feverish chills, muscle weakness, twitching, itching, denies any muscle spasms. He denies any growths or rashes on his skin. His most recent vital signs are blood pressure 141/93, pulse 58, temperature 98.2, respiratory rate 18. His height is 175.3 centimeters and weight is 70.1 kilograms, and his O2 is 100% on room air. On assessment, he is a 24-year-old Caucasian male with no known drug allergies. His eyes are perla, sclera, non-injected, non-esoteric, no bruising to the tongue. His neck is supple with no goiter. Bruising is present on the posterior as left ear, but he did deny any falling. His lungs are clear to auscultation. His heart is normal rate and rhythm. His abdomen is soft and non-tender, non-distended, and bowel sounds are present in all 4 quadrants. He has no edema to any of his extremities. He has +2 bilateral strength in all extremities. He does have a tremor with extension of his arms, and his affect is flat. Recent labs has shown a RBC of 3.74, hemoglobin of 13, hematocrit of 35. We have a creatinine of 0.78, a sodium of 132, and a CK of 17,000. The CT showed no acute intracranial abnormality, and he has mild cerebral volume loss for his age. So we have diagnosed him with alcohol dependence, with withdrawal, with complications, non-traumatic rhabdomyolysis, alcohol withdrawal seizures with delirium, delirium alcohol related, pancytopenia, metabolic acidosis, and hypophosphatemia. In our differential, we had seizures, new onset seizures, which we did the EEG, which showed no seizure activity. He did have the tremors, but he did not have any eye movement or any loss of consciousness. We also had hepatic encephalopathy, since he does have the drinking history, but all his liver studies were within normal limits, and his ammonia level was only 18. We also, on assessment, the liver was within normal limits, non-palpable, non-tender. So we also diagnosed him with delirium tremens, which he is positive for with the tremors, and the previous hospital saying he's seeing things and hearing things, and his mild sweating and not being able to do calculations. So his treatment for us was start him on a we started him on a withdrawal regime of we could not use Ativan because he does have a previous history of quitting drinking. So we had to use phenobarbital, and we started him on a taper of that. We also had him under seizure precautions just in case he did have seizures from it. We also treated him with thymine, 200 milligrams IV Q8, until the delirium has subsided. We did do the EEG. For cardiac, there was no issues. In pulmonary, there were no issues. Renally, we started him on a bicarb drip at D5 half with 1 amp of bicarb at 250 an hour to flush out for the non-traumatic rhabdomyolysis. For hypokalemia, we replaced per protocol, and we checked our mag and phos also. For the pancytopenia, we suspected bone marrow suppression in the setting of the alcohol abuse. For GI, his hepatitis panel was checked and everything came back negative, so he did not have hepatitis, but is something that they still need to keep an eye on. Muscles, he wasn't having any of the twitching or anything like that, but we could give pain medicine if needed. For our, we gave him sub-Q TEDs and PCDs for blood clot, and we also gave him Pepsid for any stress ulcers for being in the hospital. We were also kind of worried about his loss of brain matter for his age, which means that his alcohol consumption has started reducing brain matter, and we educated him about getting help, and that the anonymic aphasia may not go away since he has lost that brain matter. And this is my second presentation.